So just like I keep telling you, we're going to start with treating GAD with the basic EMDR training, okay, the protocol that you learned. So meaning past, present, future. And then first, worst, and most recent. Okay? That's pretty easy, straightforward. What we're looking for is something in the past, anything that is attributable to enhancing or starting their anxious worry. What maybe developmentally was going on? What was their family history like? What was the parenting like in their home? It can spring from traumas that are something like a dog bite, and the dog bite anxiety can become generalized. It can come on from having medical procedures done over and over again, maybe spending a lot of time in a hospital, or one incident that was pretty severe. And there are things like maybe the parents not being there the whole time, so the child got scared, and having a halo on their head because they'd broken their neck was a very frightening experience. And what we know that is that by second order conditioning, anxiety can begin to generalize to other things. Also, we know that and bullying is a big thing, and these days bullying happens on the internet, but I have cases where people were bullied 40 years ago but still suffer from it. It's not like they ever get beyond it. I'm sure some people do, but it's one of those things that stays with you. And it can create GAD, it can create social anxiety. But you're going to be looking for how is it presenting for them. There can also be attachment concerns, just like my poor little girl whose parents were never attuned to what she was feeling, what she wanted. They never comforted her if she went to her room. So we have some attachment issues, and always, actually, when we're doing history taking, we want you to be looking at attachment and how what repair might be necessary. If there are so many, and this happens in different cases that we might have, not just anxiety, but there may be so many instances that they have in their life of being anxious, and if they're being anxious all the time, it's hard to distinguish targets, or there may be 1,000 of them. And so you're thinking about that as, okay, do we have to do 1,000 sessions of EMDR therapy? No, you might remember that you can cluster them. So if there's one experience that represents all of them, that does stand out for them about their worry, then we can use that as their target. And it is hoped that by doing that one, it'll generalize to the rest as well. Okay, so you could have as many as 5 different situations or more. Sometimes people will say, even just with the more chronically traumatized and most complex cases, they'll often say, this happened my entire life. You'll hear that a lot. Okay. Any questions, you guys?
I just didn't hear about the clustering, I'm sorry.
Okay, clustering. Sometimes they have so many memories of being anxious that, or it's ongoing, it's sort of in their head rolling around all the time, that they have difficult time identifying which one do I start to work on because it's ever present. So you'll ask, isn't there one that stands out that could represent all of the other times? And it could be the worst, or it could just be one that they remember. It doesn't have to be the worst. So basically, past, present, future, first, worst, and most recent. Okay. Any other questions? I have to tell you this too. I don't know that I do this in my personal life, but I might. I worked for the Senate, and my job was to take a 1,000-page document and get it down to 2 pages so that the senators could read it. And so I tend to be really brief and to the point. And if you're missing something, if I don't explain it step by step, which I know is a big fault of mine, let me know and ask me questions. Don't feel bad about it now that we only have a couple of hours left, right, in the seminar. But yeah, just let me know if I'm confusing. All right, no questions? Okay, quiet group. All right, somatization. Somatization is one of the things that we work on that can have a range of meaning. What is it? It could be anything from somebody who has a car accident and has hurt themselves, hurt their bodies, and maybe it has nothing to do with the car accident, it's more of an emotional one. Or another person who has had a car accident and they actually do have damage done to their body that is unrecoverable. Like some people have had head injuries. Maybe you're a mathematician and you have an accident and you've had a head injury and you've lost your ability to be a mathematician. That part of your brain was damaged and you can no longer do that. So you're thinking about these people and you're wanting to know what actually is going on for them. How are they somaticizing? What's going on in their bodies? There's an interesting way, this is pretty much from basic training about somatization, thinking about, we tell the story, those of us who train with the Institute, we think about the story of actually Dr. Shapiro having had cancer. And when she had cancer, there people can use cancer for a lot of good reasons, right? You can think about it, you can blame yourself, you can say, what did I do that I developed cancer? I have somebody who just developed breast cancer in both of her breasts. She's 37 years old. She's vegan. She is a marathon runner, and she's mad as a hatter because she's saying, I'm doing everything right, and I'm the one at 37 who got cancer. So there can be lots of emotions that come up. Yeah.
You're doing good. I'm just going to move this just a tiny bit.
Thank you. And indeed, you'll have to work with that. What happened to them around the diagnosis of getting cancer? I'm using cancer as an explanation for somatic and how we treat it, okay? So with her, we target the doctor saying that she had cancer. We target her anger about it. We target what her body is feeling about it. Also before surgery, we talked to her body and let her body know what was going on, that she was about to undergo a major surgery. People don't recognize that surgery is something, if you lose a part of your body, that you're going to have emotional response to that. And as women, breast cancer and having to have double mastectomy is kind of a big deal. Regardless, it's barbaric, you guys, if you've never actually gone through it or seen it. And she's mad at her husband because he is not doing anything and he doesn't have cancer, right? He's eating chips and salsa and doing whatever he wants to do, not living a healthy life, and he has not developed cancer. Oftentimes, people will come in and tell you about horrific ways in which they were told that they have cancer. One person came in and talked to me about, I got a message on my voicemail. Oh, you have cancer, you're going to have to find somebody to work with you. Okay, see ya. That was a doctor. Another case I had was a woman who they had pumped full of liquids, and she became twice the size of her natural body. She was having a procedure done and something went awry. The nurses told her to get up, get out of bed, and go give us a urine sample. Well, she could hardly move, and she was in a great deal of pain. And when she got out of the hospital bed, she urinated on the floor. Well, she is full of fluids, right? It wasn't that she was intended to do that. And the nurse said to her, now look what you've done. So it's not just the diagnosis itself, it's how they're treated, okay? And if somebody does undergo chemo, right, or has to undergo chemo for whatever type of cancer that they have, it can be a horrific experience. Shapiro was talking about a woman who she worked with who had developed breast cancer and came to her to be assessed for emotionally, whether she could actually go through it again. She had developed cancer again, and she didn't know if she wanted to go through chemo ever again in her life. So they worked with her, just like I'm telling you, on when she first was told, maybe things that happened medically that were painful or shocking or hurtful, maybe the procedure itself, post-surgery, whatever needed to come up. And in her mind, she needed to know, will I be able to go, or should I just give up and let the cancer take me? So they worked on all of those things, and then what they did was all of the disturbance, post-operation, being healthy again, and then getting the message she has cancer again. They went back to the chemo because that was the problem, right? That was the part that was so difficult for her. So they did work bilateral stimulation. They focused on that as a target. The woman went through her experience of getting chemo, and at the end of their work together, felt like she made the decision. She felt so much better about what had happened. She made the decision that she did want to live and that she was going to go through chemo again for the cancer that had come back. When she did, she came back and reported to Shapiro that she was able to do it, and in fact, it was not at all discomforting. It was not horrible. She wasn't throwing up. And of course, they've improved a lot of chemo and how they give it to you and that kind of thing so that you're not as sick. But a successful experience, she was able to go through that. So you're thinking about past, what kinds of medical issues, and this idea, anything in their life that needs to get focused on. You work on that, past, present, future. And then you have them imagine being able to go through getting chemo and doing it well and being successful and coming out the other end healthy. So you see why we keep telling you that basically whatever we do, whatever type of issue we're talking about or thinking about working on, whatever we want to select as the presenting problem, we're looking all through their life, and whatever is going to be an obstacle to them being able to get and do and think and feel the way that they want to be thinking and feeling and doing. So one of the other things that you can do, and there's the story, it's okay, of again, another sort of Shapiro story. She had a client she had a client who was an engineer, and he was having difficulty with being able to, he had cancer. He was trying to recover, and he went to the Symingtons. And I don't know if you know who the Symingtons were. Okay, everybody's shaking their head. Some people do. Yeah.
Turn off the picture and turn it on. You can turn off, yeah. They did a lot of relaxation, visualization.
Yes, relaxation and visualization. They had studied, they were looking, the study was that they knew that people had been diagnosed with cancer, and they were interested in what was experiencing, the people were experiencing. Some people were told they had 2 months to live, and they lived for 2 months. Some people were told that they had 2 months to live, and that by doing the psychoneuroimmunology is what they named it, which is visualization and how you're thinking positively, were the people who were able to live for 5 years. So these people had positive thinking. They were waiting. Maybe I want to wait till my son graduates from medical school, or my daughter graduates from, her medical school, or something in the future. Looking positive for that and able to live. They developed a thing where you imagine yourself overcoming the cancer. All right? And what he decided to do was to think about having cancer, and since he was an electrical engineer, he thought the good idea would be to just have electric current running through his body, killing his cancer cells. Okay? Well, it was getting stuck, and the Symingtons didn't know what to do. So they sent him to Shapiro, and she did bilateral stimulation on the electricity in his body getting stuck, and he was able to move the electricity through with the idea that this electricity was killing his cancer. Okay? And then you have to practice it. So first, you come up with a psychoneuroimmunology. It can be whatever the person thinks would be helpful for them to fight. And again, I'm using cancer as my example, the cancer cells in their body that are ravaging them. It can be a religious figure. It can be something that's made up. He was using electricity. We have people who have been riding on a white horse and being a knight and just tossing the cancer cells out of their body, and this is what they're imagining while they're getting chemo. Okay, whatever they do that's helpful to them, we help them discover that, and then they do it as homework. So this man, he got the electricity running through his body, and then his positive belief, I believe, was the same one that I had yesterday. My immune system heals me. So he thought, my immune system heals me, and when he urinated, that his cancer cells were coming out. He could have the electricity go through his body, urinate, and so every time he urinated, he practiced that whole positive thinking and that the cancer cells were leaving his body. So we can do this with any type of somatization, any type of things that's coming on. There are going to be times when people want to hang on to illness of some kind. And it might be because it's a benefit to them. It might be the first time they get to prop their feet up and they don't have to do anything. They don't have to do the dishes, and they don't have to go to work, and they don't have to, be responsible. They can have other people for the first time taking care of themselves. So if there's anything that's getting in the way like that, it's not a horrible thing. It's just you want to know, is there something that's blocking them from actually being able to fully feel better? And if that's the case too, then there may be some family issues. A woman, she was actually a pastor. I'm trying to think about exactly what her title was, but at the hospital where I worked, she came to me and she told me, now I want you to sit down and I don't want you to say anything. And so I said, okay. So I did. I sat down and she said, Christy, I have cervical cancer and it's likely that I'm going to die. And I couldn't say anything. Right? So I said, okay. And she walked out of the office, and she did have surgery, and they fired her, by the way. Isn't that horrible? I won't tell you what hospital. But as a result of that, we were actually good friends, and she didn't want to see me anymore because I was the one she told about her cancer. So I became a part of the diagnosis. It's not unusual. And in families, people can run away when somebody gets diagnosed. Like the Mary tape y'all were watching the other day. Husband leaves because his wife has terminal cancer and she's dying. Okay, so that kind of thing. So if there's anything that's going on in the families, you're just trying to set them up for success to be able to work through whatever problems arise. Might need family therapy. They might need nutritional help, right? Go to a nutritionist. It just depends what is blocking them from doing the best job they can to work towards healing. Okay? What else am I wanting to tell you? We talked about the protocol, somatic protocol, past, present, future, first, worst, most recent. There is several things that you want to know. What's going on again? What's keeping them from progressing towards health and health in their mind as well? Past, present, future, secondary gains, imagery. In the imagery, I didn't finish this very well anyway, that while that gentleman was thinking about urinating, my immune system heals me, they attach that positive to whatever action they're going to be doing. If they're going to be the white knight on a white horse, then it might be the same thing. My immune system heals me while they're tossing out the cancer. But there's always a positive cognition attached to whatever imagery they come up with. I can survive. I will survive. I am surviving. I'm alive. You just have to see what they come up with. And then they run a movie of doing that. Run the movie of electricity running through my body, urinating, cancer cells go out, my immune system heals me, to a logical end of positive thinking. if anything comes up, this is like this linking positive cognition to the imagery is a lot like a future template. There's a lot going on in this building, isn't there? What they do then is they keep a log and they report back to you as they're trying to do this. If there's any difficulty, then they come to you and say, this part was hard, I'm not able to complete that, and you work on that. That becomes the target for the day. And self-care, that's going to be anything they need to take care of themselves. Again, if it's nutrition or any kind of edification, what is it that they need? What's lacking to get themselves better? Okay. I want to tell a story, and then this is actually where Priscilla's supposed to take up.
Can I ask
Okay.
a question?
Yes.
Did Francine use the typical protocol?
Yes, she did.
Yeah.
Yeah.
For the electric
Past-
city that
Past, present, future. Then they come up with positive imagery and a positive cognition. As they're running it in the future template, they imagine the positive with whatever it is they're choosing. Some people choose, again, a religious thought or feeling. Run it to the end, past, present, future.
when you say past, present, future, explain it again.
Okay. What in the past laid the groundwork for the present disturbance? So we're looking for the first medical issue. Was it the phone call that they got, or the mean nurse that was handling them, or whatever, the chemo that was so destructive? Anything that comes up in their life.
But within the realm of the most recent diagnosis.
Yeah, whatever presenting problem they're coming in to work on. Yeah. Yes.
If there's a secondary gain, how do you do that with your tests, or how do you work with that?
Well, first you have to have a little conversation about secondary gain with them. Is there any reason that this would not, that you might not want to get better? Or what's so good about being ill? You know, you can ask them, you know, sometimes they'll look at you just like you did a little bit like, what's good about being ill, right?
You don't have to go to the family holiday party and deal with all those people. Yeah.
Right. Priscilla says you don't have to go to the family party and deal with all those people. Our son, somebody was talking to our son and asked the question, what's your family life like? He goes, oh, we're a white family. We're like, oh, okay, you know, whatever. Yeah, that family, I don't want to go to Christmas. Okay, so did I answer your question? Yeah? Okay. So let's see. Secondary gain, did I answer your question?
Yeah, did you add BLS then? The secondary?
Certainly if there's something about, like, it's the first time anybody's ever cared. It's the first time anybody listened. When you are going through something, it's pretty difficult when people don't get it, right? And we were just talking, again, Priscilla and I have been together for this whole week, but we were just talking about something. I'm going to give an example of secondary gain. That's not really secondary gain. Well, it just feels good to be heard and to be understood. And that may make you want to stay sick. But could you get better and still have people treating you well or listening? Is there something we could do to help you have that happen in your life without having to be sick? Right? You're just trying to find out an avenue out of any blocks.
Do you want me to give some examples of secondary gain?
I think I gave some, but please add more. Whatever you're thinking. Oh, you know, I didn't talk about the benefits,
Well, I'll just
except for sick.
Yeah, I'll just jump in. Yeah, so just a couple things. I had one lady where she was unable to eat due to a choking trauma.
Uh-huh.
And she was quite a heavy woman. I mean, she's probably 250 when she came to see me. I didn't realize she had lost 100 pounds. So I foolishly did not explore secondary gain, and she brought it up to me, where she said, "Wait a minute." She said, "I think there's secondary gain. I think that's why I'm stuck." She was a nurse. She was very articulate and smart. So we had to come up with a plan for what to do to continue the weight loss once she started eating again.
Mm-hmm.
So so we did the detour protocol on overeating, because she was a chronic overeater, and then she was able to make progress. But another example is, when I was a kid, when we got sick, we got popsicles, we got a coloring book, we got individual attention from our parents, which we never, would usually get, And there's lots of people, you go to the hospital, the nurses are nice to you, the doctors are, so there can be that sort of thing. It can also be, if I have a headache, there's any number of things that I can avoid doing, I don't have to have sex with my husband if I don't want to. I don't have to go to work. I can avoid family interactions with difficult people. That's secondary gain. The other thing is just disability check. That's another type of secondary gain that's very important to address.
Yeah. Well, you think about the veteran population, that also their identity, and maybe Priscilla's going to talk about that here in a minute, but yeah, if they don't have PTSD, that their benefits get taken down, at least diminished. So what's the point in getting better? That on top of the fact that you don't get to go have coffee with everybody else who has PTSD, your comrades, people who've been with you for a very long time, you know them very intimately, and you are a group. Here, they are your people. Will you suddenly be cast out because you're different? So there's 101 ways in which we might benefit from not getting better. 101, or 1001 if you like that better. And then I'm going to tell a story about a woman who was taking care of her mother. She moved into her house, and this is another type of somatization, and I like telling this story. She was taking care of her mama. She was dying, and they got into a really big fight. And they had had a sort of tumultuous relationship their whole life, but this felt like it was going to be a healing moment together, the end of her life. Her mom got so mad at her that she kicked her out of the house, and she wouldn't speak to her until after, she died, and she never spoke to her mom again. She came into me for treatment about this particular thing, and so we worked on what it was like, the pain around losing her mom, the pain around being thrown out, the pain around not being able to actually say goodbye to her in a way that she wanted to do it. And we got through all of that, you guys. So she was feeling much, much better, and we got to, past, present, future, we got to the body scan, and I did exactly what I was supposed to do, right? Hold in mind that memory and the positive belief, and scan your body. And tell me if you notice anything that's still disturbing left in your body, head to toe. And she said, yes, there is. I have this problem in my neck. And I said, okay. So is it okay if we just focus on that, on your pain in your neck? And she said, oh, Christy, I've had this for 10 years. And I said, well, you just never know, right? I'm always like, would you like to remain curious about what might happen? She goes, sure, okay, we can work on it, but gosh, it isn't gonna do anything. I know that. And so, okay, let's just try. So we focused on the pain in her neck and her back, and did bilateral stimulation on it until it had gone away. All right. She said, oh, it feels gone. It feels really so good. And I said, oh, I'm so glad. Oh, but when I get home, it's going to come back. It'll come back, and maybe even tomorrow or tonight. I'm not sure, but yeah, it feels good for now. I said, okay, that's fine, because I never know. I can't predict that either. And she came back the next week, and she said, it's still gone. And she's kind of looking like this. It's still gone. And it turned out that as we talked about it in reevaluation, that pain in her neck came about when her mother died. Right? When she was thrown out of the house and her mama died, that pain and she'd been to PT, and she'd been to all kinds of doctors, and they were trying to work on it. And I mean, this had been 10 years in the making, and she was able to release it. So that's other ways in which we can use somatic protocol. Yeah.
So you're doing the bilateral and you're having her focus on that, and does she talk or you just do the bilateral holding?
Okay, good question. So when you're focusing on the body and that part that was in pain, do you keep doing bilateral stimulation, or what was the last part?
Do you do a set and then stop and check in?
Okay, do you do a set and then stop and then check in? Yes. So you'll do bilateral stimulation, stop just like we would normally stop, ask what are you noticing now, and they're going to tell you, oh, it's a little better. I think it's a little better. Okay, notice that. And you're just focusing on it and you keep doing the same thing, bilateral stimulation, stopping and asking, bilateral stimulation, until it's gone.
So they don't come up with a story. Does she start talking about all the things it's coming from?
No, she did not. Though that can, okay, the question was, they don't come up with a story. And she did not come up with a story. It was just the pain. That was all that we were working on and all that came to her. But other people do. They go, oh my gosh, this is connected to whatever it's connected to. So anything can happen. And that's part of the reason we don't do the body scan if we have 5 minutes left in our session, right? Is because something has happened to me. It's a terrible thing. You're thinking, yay, we're gone. Let's finish this thing because it's so exciting. And then you tap into something horrific, right? And you go, ay, ay, ay. I got to leave this person here. Not so great. Yeah. Thank you for asking. That's a good question, yeah. Okay, any other questions? Oh, self-care. I think I talked about that. Yes, go ahead,
let's
Priscilla.
talk about, but before we talk about self-care, could you talk a little bit about your experiences working with the people who had suffered the loss of a limb?
Oh, yeah,
and the
I can.
phantom limb pain?
Yes, I certainly can.
Can you repeat the question?
Can I talk about, Priscilla wants me to talk about a case where phantom limb was in play. How's that? This is my best shot at that, repeating that question. Okay, sad story. Sometimes I get moved by it. As you know, we've traveled all over the world doing trainings, and most of the time we're training for particular people who are in a bad way. We were asked to come to Bogota, Colombia, where I lived as a child. It was really fun. I've actually been able to go back to everywhere I lived as a kid through EMDR therapy. Yippee! It's exactly what I wanted. So we were asked to come to Colombia to do a training where there was a home for children who had been left at the doorstep because they were either dying or chronically ill. An orphanage. And we always laugh about this. I was actually with Laurel. We laugh about this because people think this is really glamorous work. We were in a cartel's home. It was empty. And there were bullet holes all around the place, right? And we're on the floor, sleeping on the floor. So not so romantic, some of these trips. But anyway, there was a child there who had her leg amputated. She had cancer and had to have her leg amputated. And she was screaming in pain and screaming and screaming and screaming. And they asked us, is it possible that we could do something for her? So we did EMDR on her, and we, being a team, this was never done before on a loss of a leg. And so we as a team worked on her. And it was this fast, you guys. And somebody asked me earlier, do children always work so quickly? And no, they don't. It just depends on what the situation is. But we set up the thing about her pain in her leg and started doing bilateral stimulation. The first pass, screaming about the pain. Second pass, it's feeling a little bit better. Third pass, she started crying about that her parents had left her. So we dealt with the loss, right? Being left on the front porch. And then she started crying like fourth, fifth, somewhere down the line, 20 minutes later. We did a pass where she said, this is interesting. I am no longer in pain. Probably didn't use those words, but I'm not feeling the pain. And we said, notice that. And we kept going. And then she worked on the loss of her leg, right? Okay, so grieving the loss of her leg. Slowly but surely, she improved until she wasn't having any pain left at all. Okay, and we wrapped up the session. That not quite. Sorry, there's a really not poignant piece to it. What she last said before we stopped, as a positive, was, "Wait a minute. I can't play." Oh yeah, tears about not being able to play with the other kids, and then, "I can play with the other kids. Wait a minute. I'm going to get a prosthesis, so I'll be able to run and play again." Notice that. Okay, it was the first time that we had ever worked with phantom limb, and then Sandra. Was it Sandra who did the research on phantom limb? Remember?
I think it might have been Linda Vanderlyn and
Linda, yeah.
Sandra
Linda,
Paulson.
yeah, Sandra Paulson. It wasn't Linda that did the research,
Yeah.
but actually, Linda's the reason we were there. She had a connection. I guess it was her sister. Do you know Linda? Okay, yeah. So her sister was the connection to ask us to come do the training there. Anyway, so that's the story. And we went back about a year later, and the child was still doing extremely well, and no more phantom limb. So they did research on phantom limb for the first time after this experience. It was not I, Sandra, somebody. I wish I remembered. And her husband, I believe. Wasn't Bob Tinker? Yeah, I don't know if it was Tinker or not. Anyway, Priscilla, we'll look it up and we'll tell you before.
Marshall
Lewinsky.
Marshall.
Oh, Marshall Lewinsky.
Wilensky.
Oh, Wilensky.
And
Marshall Wilensky.
Arnie Hoffman,
Arnie Hoffman.
Jen Schneider,
Jen-
Christine Roast,
Jen Schneider, Christine Roast. Are these
Francine Shapiro.
and Francine Shapiro? Are these just studies?
Yeah, these
Different
are-
studies, yeah.
Published articles on phantom limb with EMDR.
And it was the first time, and I'm sure there's maybe a couple more in there, but it was the first time actually that we were able to find that you could help somebody with phantom limb, that in fact their phantom limb could no longer be a problem to them. They don't have to have the pain, they did not have to have the suffering, and you can imagine what that means for military, especially people who've lost limbs. Yes?
So, with the child, did you go through the desensitization process before the BLS too, some of the whole thing, or was she just kind of narrating when you were giving the BLS after
Well,
each thing that you noticed you had to kind of target and pay attention to?
sometimes, okay, so the question is, did you set up the target, right, with an image, a negative belief, and all of that? And sometimes when you're in the field, you just do what you need to do, okay? And yeah, we're triaging. And the child was screaming and writhing in pain. So to do all of that, we felt like was going to be worse for her than to try to just start. So when you think about this, what's going on? My leg. It's bilateral stimulation. And we just followed her to the end. Yes.
Could you use this for, I know sometimes elderly people, if they fall once, they then become a very high fall risk because they're so afraid.
Uh-huh.
Could you, I mean, is that like a single incident trauma that leads to anxiety? How would you frame that?
Okay, so let me try to repeat that question.
Sorry.
When you have an elderly patient who has fallen, they're more likely to become anxious and fall again because they hurt themselves. Next part of the question, please.
How would you approach it?
How
would you set up?
how would you set that up for treatment, for processing? Very likely, you'd have to, depends, you might do past, present, future, but you could start in the present with the current fall or the recent past fall, and you just set that up like you would with an assessment phase, image, NC, PC, okay, all of that, and treat that fall. And that'll bring out, likely, the fears about falling again, what it was like, the horror of it, the pain of it. And I tell you, there I have somebody who I just trained basic training with, and he works with the elderly, and he's doing all kinds of work. There's not a lot of research on the elderly with EMDR, and so he's starting to working with them, and it's really working well. I have worked with people who are elderly who are getting ready to die to help them not be anxious about dying. I have helped people, the elderly, very different kinds of things, maybe a disease. Uh, yeah, a disease. I was trying to think about any of my elderly cases, yeah. So it's just like that.
Have you worked with, did I interrupt?
No.
Have you worked with the elderly who are, that horrible place where they're losing their memory and they know they're losing their memory and they become so anxious about it?
I have not had a case like that. I know several people like that and have lived with family members like that, but I have not had a patient who I worked with EMDR. Oops, I didn't say the question. The question was, have I ever worked with somebody who's in the place where they're losing their memory and they know they're losing the memory? So that moment of kind of horror that something's coming down the pike, right? I have not ever worked with somebody like that. Have you, Priscilla? Yeah. You want to talk about it?
Sure. So, incidentally, it's a very interesting thing. Usually, the window in which people become horrified about losing their memory when they're developing dementia is very short. Because when we develop dementia, part of the brain that goes is the part of the brain that lets us know we have a deficit. It's called anosognosia. That's inability to know that we have a deficit. So most people who really have an advanced dementia are not aware. They're like, my memory's fine. And then you test them, you give them 5 words, 5 minutes later, you come back and you ask, they have no idea that they actually, they get 0 out of 5 and they don't believe you, that they have a memory problem. Well, my uncle was diagnosed with Alzheimer's by the neurologist, and the neurologist said to him, you have Alzheimer's. And he said, well, that's your opinion. It's pretty funny. And I'd been so worried. I had this whole plan, we were going to go out to his favorite hotel, to the in the Berkeley Hills, and we were going to sit and overlook and have a glass of iced tea and look at the sunset. Had all these plans about how we were going to, because this is a very high functioning man. And he was like, well, that's your opinion. And so we were sitting out and I said, well, what did you think, Uncle Bruce, about what the doctor said? And he's like, what doctor? But however, I had an unusual case of a woman who she wasn't actually developing memory problems. She was developing a different kind of dementia. So she was having a very overall cognitive decline with intact memory and intact understanding of her deficits. And she was coming to me because she was failing at work. She'd been doing this very high level job doing evaluations of blind children. She'd been doing it for years and she could no longer do it. And she was very anxious, and we worked through a lot of the anxiety. We, were not able to make the cognitive disorder go away. She was developing a major neurocognitive disorder or dementia, but we were able to get rid of the distress around it using EMDR therapy. It was really, beautiful. Yeah.
I think
Okay.
I'm done. I was
You
thinking
think you're
about
done? You want me to do self-care?
Yeah, because I think I'm done.
Okay.
Thank
Be
you,
done.
Priscilla.
That's
Yeah.
your self-care.
So what we mean by self-care here is not the typical self-care that, we want people to do self-care where they take care of themselves. But what this is where we want people to use this positive imagery that they've developed for their somatic problem. We want them to use it several times a day. So in the example that Christy was giving you, when he would go in to urinate and imagine the cancer cells leaving his body, he would look from one side of the room to the other while he was urinating and imagine the electricity running through his body and killing the cancer cells. So the idea is that the person spends several times during the day where they bring on their positive imagery with their positive cognition about healing their immune system or healing this problem, and they add in some kind of bilateral stimulation. So we have people practice that several times a day. So people have all different kinds of things that they use. They have a healing light, or people imagine, there's one person who you can do this for the flu. So there was a person with the flu and they imagine oxylocosinum, which I don't know if you guys know what that is. It's a homeopathic that people take for the flu. She was imagining oxylocosinum man coming in and sweeping away the flu virus, So you can have all kinds of things like that. So the idea is you just want them to be practicing this healing imagery several times a day with bilateral stimulation.
Did it work?
Yes.
With the flu?
Yes, it worked with the flu. Yeah, actually a great example of this was when we were in Bangladesh, our old co-trainer, Liz Sniker, we got there and I don't know what happened, but there was all kinds of illnesses rolling around there. People would, meet you, they'd be coughing and they'd be like, "Oh, hi, I'm so sorry about my cough. I have terrible typhoid." It was really lots of diseases there. It was really intense. But somehow the entire team started coming down with some sort of contagious bug that looked like it was going to be having a lot of gastrointestinal effects. And I said to her, I said, I don't know what we're going to do. We're here for 2 weeks. This was right in the very beginning. I said, I don't think I'm going to make it. I don't know what to do. Like I have to be your co-trainer here. So we were doing this extended training for 2 weeks in Bangladesh. And so she did the somatic protocol on me about getting sick in a foreign country. And we were just chatting at lunch. I've had this very unusual history of I've had so many illnesses in foreign countries. So, I've had viral meningitis. I got dengue fever. I have had all these injuries. I almost severed my finger when I was in Cuba. The list goes on and on. So it was very interesting, though, because we went, you go back to the past. So we went back to the past. When we were children, we'd go to Mexico every other year with our parents. We'd drive down deep into Mexico in the VW bus, and we'd stay in campgrounds, or, we'd stay, there was one place we used to stay in Guaymas, where they had like a little place for people to park their campers or their motorhomes, and there was a hotel attached. We used to go there. And I had this image come up of being alone on New Year's Eve and being 10 and being abandoned by my parents, sick in a foreign country, while everyone else went to the New Year's Eve party. And I was 10 or 12 or something like that. So we reprocessed that memory, and it was the most interesting thing. I realized that I told my parents, go to the party, I'm fine. And the distance from where we were parked to the party was like, 200 feet. So it wasn't like they were abandoning me. And I had, I fell asleep, but they were coming to check on me. So that part, somehow I got laid down in the nervous system that I was abandoned while sick in a foreign country. And in fact, that's not what happened. And as soon as I reprocessed that, I started to feel better. And then Liz had me focus on the body sensations related to the current the current immune response I was having. I was having like aching muscles, when you feel like your bones ache. and a lot of gastrointestinal distress. So we kept reprocessing. It was about a 90-minute session. We reprocessed for like an hour just on physical sensations. I feel like I have a fever. I feel my bones aching. I feel my stomach hurt. Now I have a pain in my neck. Now I have a pain in my back. We were just sort of chasing it all around the body. Then we got to the positive imagery, and I had a positive imagery of this healing kind of light coming in. And then we had this positive cognition. My immune system heals me. I'm healthy and strong. And we went through that. And then I went home. I slept 9 hours. I woke up in the morning and I was fine. And she also worked with the rest of the team that got sick. And they all had the same response. And it was really interesting, where it really works. So this somatic protocol can be used for that sort of thing. It can also be used for more traditional types of somatization. So when we think about somatization, kind of like my client with the blindness, who thought he was going blind, that was actually true panic. I mean, that was really a panic disorder masquerading as, temporary blindness. And so if it really feels like it's more of a panic disorder, then you can work on it that way. But what other kinds of somatization responses have you guys seen? Yes.
Well, I'm sitting here thinking of my client that has had this lifetime of constipation, and she's in her 40s. And so I'm just imagining trying this with her, because she physically has to go and
Perform surgery.
Yes.
So there's a client who's had it in her 40s with a lifetime of constipation, where they actually have to go in and pull it out in order to get it to go away. Yeah,
this is her belief.
that's her belief. Yeah. Has she ever had like an actual fecal extraction at the doctor? Is it that bad? Because they do that, I think.
She has done rectal Valium.
Rectal Valium.
She's done different antibiotics for her GI tract.
Yeah.
She's done
Antibiotics for the GI tract.
she's done lots of different medical.
Lots of different medical things. Yeah.
Colonoscopies,
Colonoscopies, yeah. It's interesting. I have a client, she doesn't have lifelong constipation, but she was having work stress and severe constipation. And we did EMDR for it. And it actually really helped. It really helped quickly with her. Your client, it might take longer.
Yeah.
With my client, we had her, focus on actually the idea of relaxing the bowels and going,
Her
Just-
doctor, my client's doctor, told her that she has a very tight
sphincter. Her client's doctor told her she has a very tight sphincter. Yeah. Yeah, so you can actually target the sphincter. You can have her target the sphincter and imagine it opening up. Yeah. And in a few minutes, we're probably going to do progressive muscle relaxation. You can have her practice that, targeting on the muscle of the sphincter. So progressive muscle relaxation is where we tense and relax all the major muscle groups in the body. And just doing that alone might also be helpful, So a lot of times with these folks, we have to get a lot of pieces on board. Sometimes they're not having fiber, because fiber is huge for constipation.
She's so past fiber. And
She's past fiber.
She's
Yeah,
like,
she's way beyond that. Yeah.
Yeah.
Yeah. So, so definitely it would be starting with when she first developed the problem, what was going on.
so she was a baby.
She was a baby.
The narrative to her is that she's always.
Okay, so the narrative was that she's always had it. So, is anyone familiar with Katie
O'Shea.
O'Shea.
And Sandra Paulson, yeah.
Yeah, okay. I'm sorry, she's changed her name several times and I keep going back to the old names, so it's terrible for me. So yes, Katie O'Shea. So Katie O'Shea has this lovely protocol where you have these early childhood things and you tell the childhood story. So if you know what the childhood story was about constipation, I would start with that.
Okay.
So, and you could even as the therapist say, okay, tell me the story again of what you know. So I was born and this was happening as a baby, you know, and even if it was something that was really a real medical thing, you know, there was a client who, when they were 6 months old, they were in a full body cast for 6 months. And they caused DID, dissociative identity disorder, because they were having such a difficult time being in this state where they couldn't move as a baby. Yeah. So, yeah, so I would have her start by reprocessing that first story and whatever distress is related to that. You know, that's the first time. And then what is the worst time that she's had it? And then the most recent time. And then the healing imagery can be around opening up the sphincter and her microbiome resetting and, you know, whatever else she needs to be able to have that change. Yeah.
In Katie O'Shea's protocol, the question that she would ask would be, what, like as a baby, going back to the baby, what needs to happen for you to be able to go to the bathroom? Visualize that.
So in Katie O'Shea's protocol, one of the questions is to go back and ask the baby, what do you need to be able to go to the bathroom? Yeah. So what I was specifically talking about is she has a protocol where when people have had something happen to them, particularly attachment related things, where with people where they don't know, you could have the parent or the caseworker or somebody tell the attachment story while you're doing the bilateral stimulation. But I like that as well, and I believe that that is part of the way she works. Yeah, yeah. So that's a nice thing you can do there as well.
I'll try.
Yeah, yeah. With my client, whenever she gets stressed out, that's where her body goes, is to constipation. And so we've worked on this healing image of kind of being able to go and let it all out, and she doesn't have to hold the stress and she can release it. And
So
yeah.
interesting, because so my client can identify that when she's in high stress, she can go to the bathroom. Like,
So your client, when they're in high stress, they can go to the
or when no one's
bathroom.
in the house.
Or when no one's in the house. Yeah.
So it's like, if there's anything medical with her gut, like that's over here, but there is definitely like an emotional, you know, component.
Yeah, if
around
there's no
release.
one in the house and she can go, that's a sign that there's something emotional going on. Yeah, because people really do have physical things. I had one client who, he had all kind of urinary problems. He bedwet until he was 15. And he went to shrink after shrink after shrink. And then it turned out he had some sort of rare medical thing where it required a surgery. And they gave the surgery and then he was fine. But he came to me for EMDR about all those years being, you know, told he was a psych patient. So we actually had to work on the trauma related to that.